Okay, so what is CB-IMNCI? Okay, CB-IMNCI means it's a community-based integrated management of neonatal and childhood illness. So it's a community-based integrated management of neonatal and childhood illness. Okay. So in our health post setting and primary health center setting, so we used to follow this guideline, okay, CB-IMNCI guideline for management of different childhood disease or childhood disorders. Fine. And it's called CB-IMNCI. So you can find here two components. One is neonates, another one is childhood. Okay. So neonates means one is neonate, another one is childhood. Neonates means under 1 year or 1 month. What is the full? What is the meaning of neonates? What are called neonates? It's a newborn. Okay. Another one is under 5 children. There are two groups. So basically, previously we have two components. One is called CB and CB. Another one is IMCI. Only. Okay. That means integrated management of childhood illness, IMCI program. Another one is CB-NCP, community-based management of neonatal program. Okay. NCP program, NCP, neonatal program, and another one is management of childhood illness, IMCI. Okay, integrated management of childhood illness. Later, those two programs merged together, and they started the new one, and which is called CB-IMNCI, community-based integrated management of neonatal and childhood illness program. So we need few more classes to accomplish this module, to complete this module. So in between, you need to read again and again regarding different, components of CB-IMNCI program, different plan policies, because you recently, completed your exam. Now you are free, and it's more important for your practical purposes. Okay, so you will be posted as a medical officer, okay, or as an intern. So you find number of under 5 children, and if you follow the IMNCI protocol, so it will cover 90% of illnesses or disease. You can manage 90% of illness disease. So based on this protocol, and only 10% you need to refer to consultant, okay, pediatrician. And these are some of the guidelines or protocol developed by Minister of Health and Population, especially Department of Health Service, IMNCI section of Nepal. And you can find these documents in their website too. And you can see these are some of the training manuals and the photograph related to CB-IMNCI, okay, different illnesses or different childhood illnesses or conditions, clinical conditions. These are some of the photographs while I was there as a trainer, especially for healthcare workers, medical officers, or health post in charge, HA and other, for DTOT training, district level training of trainers. Okay, and these are the strategies. I don't want to go in detail. Okay, this is basically for those health workers who are currently working as in charge or prescribers for under 5 children at health post or PSC, primary health center, where pediatrician is not available. And you can see there are different causes of newborn deaths in Nepal, and this data is quite old, but it's from extracted from their guideline. So I'm using this. Though in the latest guideline too, the scenario is almost the same. In the context of COVID-19, now you are hearing every day case fatality, infectivity of disease, virulence of disease, pathogenicity of disease, and the infection leads to the sepsis. Okay, and especially in our neonates, okay, the neonatal sepsis is common cause of neonatal deaths. And how sepsis occur? Due to infection, and it is supposed to not have any infection in our health institution. Okay, so we are discussing about institutional delivery. Every day, every year, our percentage of institutional delivery is increasing. But you can see the sepsis is the challenge. So there is a gap between infection prevention control within our hospitals also. So in our renowned healthcare institution, the infection prevention protocol is not up to date. Or doctors or our healthcare providers needs to be more concerned related to prevention of sepsis. And this may be our fault. We need to be very cautious. Okay? And other are sometimes prematurity or low birth weight, sometimes birth dysphagia. Okay. And under 5 modality, okay, considering neonates, definitely prematurity and other disorder like sepsis, still diarrheal disease, pertussis, meningitis, okay, ARI, few due to congenital anomalies, due to some syndrome related or without syndrome. So that's why we need protocol. We need guideline for reduction of neonatal deaths or under 5 deaths. At the time, they thought we need to launch Vision 90 by 20 program. And since last 5 years, I'm taking this class, okay, for CB-IMNCI program. Now it's year 2020. Now, actually, we need to analyze what is the latest update. Okay, you can see by the 2020 this year, there should be 90% coverage by institutional delivery. Is it so? Do we have 90% institutional delivery? It's not. So we are not, achieving this Vision 90 by 2020. Access to antibiotic, it's not. ORS and zinc, it's not. Access to chlorhexidine gel but nabimolam. Okay. So in their umbilical stump, the neonates are newborn umbilical stump. To prevent sepsis or infection, we use chlorhexidine gel or nabimolam, and access to 90% is doubtful. So we failed to achieve Vision 90 by 20. Vision 90 by 20 means this year, in the year 2020, we need to have 90% coverage of institutional delivery, antibiotic access, chlorhexidine gel application at birth, and ORS and zinc access. But we have failed to achieve this vision. Still we have few months. Okay. I don't want to go detail regarding the backgrounds. This slide is available in my website. You can go to modules and you can find these slides. You can read there. Even the recording is available through my page, so you can also watch there. There are many programs. So before launch of CB-IMNCI. So in the year 1982 till 2000, we have vertical program. Vertical means it's like a single program, okay, without any integration with other. To control diarrhea, separate diarrheal disease program, CDD. To control ARI, we have ARI program. They are not integrated. Then in the year 1997, they thought we need CB-IMCI. Okay, and they launched CB-IMNCI program, which is Integrated Management of Childhood Illness, in the year 1997. And by the year 2009, the CB-IMNCI program was implemented throughout the country. And they thought that we need to merge CB-IMCI and CB-NCP program. And in the year 2012, they started integration of those programs, CB-IMCI and CB-NCP program. Regarding CB-NCP program, you can see it's piloted in 10 districts in 2008, scaled up in 41 districts by 2011, and CB-NCP package revised in 2019. Actually, they merged together and they released CB-IMNCI program. They launched CB-IMNCI program. So in the year 2014, they merged these two programs, CB-NCP and CB-IMNCI. I don't want to go in detail, okay, regarding this. But what is the rationale behind integration of these two programs? Because the treatment modalities is almost same. The flow of flow diagram, or flow of treatment, referral mechanism, or some precautions or take-home message to the mothers or to caretaker are almost same. So program duplication is always a challenge for population health. So they thought we need to merge CB-NCP and IMNCI program. And these two programs used to be run by female community health volunteers, or also called backbone of our health system. Due to overburden to implement both programs, as well as other different programs of government immunizations, nutrition, as well as from other NGO and other organizations and their own activities, it's very difficult for FCHBs to manage or implement this program, because the FCHB program, Female Community Health Volunteer Program, is volunteer program without having any salary. It's only some incentive based, though nowadays they used to get good incentive as well as recognition, as well as some incentive from private hospitals too. But our FCHB program is voluntary program. Despite implementation of both programs, CB-NCP and CB-IMNCI, the impact was not up to the mark, because despite FCHB involvement with incentive to the clients, patients, we have only 7% PNC coverage, postnatal care. PNC means postnatal care. Only 7% postnatal care coverage. See this scenario. Only 7%. Out of 100 sepsis cases, our FCHB can manage only 1.5. Means they were able to manage 3 cases out of 200, which is not good. Very low number of the asphyxia managed by female community health volunteer, especially in home delivery. Interestingly, only 33% of female community health volunteers used thermometer correctly. And there are other issues which you can see in your screen, on your screen. So only 11% of mothers contacted the FCHB when children were sick. The remaining directly go to health centers. So they try to escape female community health volunteer because of the above problems: incorrect use of parameters or technical capacity. That's why they merged CB-IMNCI. They started CB-IMNCI program. This is the rationals. So what are the rationals of initiation of or launch of CB-IMNCI program? You need to write these things. So shifting of care-seeking behavior of mothers and families towards trained health worker is necessary. Another major guideline is WHO changed the protocol in the year 2014. So we need to follow WHO protocol. So our government already revised CB-NCP and CB-IMNCI program. It's CB-IMNCI. So I don't want to go detail related to cross-cutting issues in other. So let me talk about FCSB and CB-IMNCI. What is the relationship between these two? FCSBs are the key players of community based on health promotion programs in Nepal. Okay, you all know, based on natural and history disease, we have different level of prevention: primordial, primary, secondary, tertiary, even we have quaternary prevention levels. So for health promotion and prevention, our female community health volunteers are instrumental. They are a backbone. And the community component is an innovative approach and modification to initial WHO-IMNCI approach. Actually, if you want to know, if you want successful community-based health intervention, any health intervention, you need to involve communities or local people. Even in the context of COVID-19, if you use community person or families or community members, then definitely we can control COVID-19. Otherwise, it's very difficult. For example, if some people who know foreign returnees come to their community, and the best person to report these things or identify these things are community people, not the government officials or ward persons, ward chairman and others. So where we failed in the ongoing COVID-19, we are using RRA approach. Actually, we need PRA approach, and I'm also advocating for PRA approach here. So RRA approach means rapid rural appraisal. All policy used to be made by government, even in especially in Kathmandu, and they try to launch that program in the community, which is wrong. So this is like project or program based or NGO driven, donor driven program, PRA. Sorry, PRA, RRA, rapid rural appraisal. But for real implementation, we need to use RRA, sorry, PRA approach. PRA means participatory rural appraisal. PRA approach, RRA means rapid rural appraisal. So we need to use participatory rural appraisal. Participatory means community participation. So community participation is key to implement any program. That's why our female community health program is one of the successful program of Nepal because of community component. So if you want to get rid of this corona prevention, we need to use participatory rural appraisal or community participation. So at BCC matrix, what is BCC matrix? BCC means behavioral change communication. We have different handbooks, guidelines, leaflets, other documents, online and printed. For any health education program or health advocacy program, we need BCC. This means behavioral change communication materials. And another one is called COMBI approach. COMBI. COMBI means communication for behavioral change. You need to communicate in such a way that you need to change the behavior of people. And it is relevant in the current context of COVID-19. Okay, our journalists used to say that we need to maintain distance. They used to report for others, but they are not following, even doctors and the public. So behavioral change is very, very difficult. It takes time, but there is no option. This is called COMBI, Communication for Behavioral Change Initiative. So why integration? Integration helps to decrease the resource required. It improves the outcome. It's more holistic. Sometimes needs less expertise. And it's based on SOP, standard operating procedure. Specifically for under 5 children, you can find different diseases together. Sometimes ARI, sometimes diarrhea together. So we need to use integrated clinical case management, not separate like ARI management or diarrhea management. We need integration. That's why we need to integrate these programs. To summarize, why we need to follow IMNCI to reduce under 5 mortality, focusing on neonatal mortality. And it's possible through this simple tool. Hopefully, it is more cost effective, even cost benefit. So benefit means in terms of money. Okay, cost benefit analysis in terms of money. Cost effectiveness analysis in terms of outcome, not money. So in the healthcare setting, cost effectiveness will be more practical than cost benefit, because our health, we can't measure in terms of finance. It's quite difficult, though they have many tools, but it's difficult. With the application of primary health care, we have 4 principles and 7 elements of primary health care: equitable distribution, community participation, intersectoral coordination, and appropriate technology. These are the 4. So with the use of appropriate technology, with intersectoral coordination, community participation, we need to manage our under 5 children through this CB-IMNCI program. There are many supporting partners for this program: UNICEF, USAID, WHO, CARE, UNHAT, PLAN, GSI, that is UNICEF International, EDRA, Health for All projects. So this is all about the background of CB-IMNCI, all the rationales and justifications. Now we're going to talk about more technical part, more medical part, okay, medical related, like so how to proceed for clinical management. And this is very, very useful in your pediatrics too. So based on IMNCI, we have 2 groups. One is 0 to 2 months. Another one is 2 months to 59 months. So 2 groups. Now, let's forget all the guidelines, CB-IMNCI, IMNCI, all. Now let's concentrate on CB-IMNCI community-based integrated management of neonatal and child illness. Under this guideline, we have two groups of children. One is 0 to 2 months, another one is 2 months to 59 months. And their management and their behavioral process are quite different. Though the principle is same. When to refer, when to call for OPD, when to call for follow-up, which are almost same. So we have two groups, 0 to 2 months, 2 months to 59 months. So what is the overall IMNCI case management process? There are different disease conditions under IMNCI. And we used to classify the severity of the disease based on color-coded triage system. Red, urgent pre-referral treatments and referral. Yellow, specific medical treatment and advice. Red means a referral. Yellow means medical treatment and advice. And green means simple advice for home management. Green, home management. Yellow, you need medical support and follow-up. And red means refer, urgent. This is the common process. In our ICM, even during your FHE, I taught you how to examine children, how to examine patients throughout the DRC file. Though it's not up to the mark, but I hope you learned from ICM. So first, you need to assess the child, okay? Assessment of the children. Actually, we have history taking and examination. And examination, we have different system. And we need to inspection, palpation, percussion, and auscultation. Better is inspection, palpation, auscultation, and percussion, because percussion is quite painful. But after being a doctor, we used to start from auscultation. And it is quite, here the term is quite different. Assessment is to taking. Then classify the child illness. Based on your knowledge, based on guideline, you need to identify the treatment instruction. Counseling is very, very important to their mother or caretaker, because of under 5 children or units. You need to be very cautious regarding how to solve the feeding problems of units for breastfeeding or for soft food, okay, for more than 2 months children, and take care of their own health. When a children or mother is brought back to healthy, especially children, to give follow-up care and if necessary, you need to reassess the child for any new problems. Don't only follow up the particular problem, you need to be more holistic and try to access other problems too. Because there are many studies. There was one study from Bangladesh in the year 2000. So they studied 1,302 children, and it was found that since last 15 days or 2 weeks, among 6 children under 5 in Bangladesh, you can find almost 20.5% had at least 3 symptoms. 18.6 to only 15.3% had 1 symptom. So what it signifies? Almost 85% has more than two or more than 2 symptoms. That's why we need integrated management of child illness. We need to be more wise enough to manage all the problems of our under 5 children. So this is the rationale. Single diagnosis is inappropriate because presenting with cough or fast breathing, there are many differential diagnoses. Maybe pneumonia, ARI, maybe severe anemia, or fast breathing only. Lethargy or unconsciousness, sometimes cerebral malaria, especially in the right region, meningitis, severe dehydration, or very severe pneumonia. Sometimes rash, like measles rash, due to pneumonia or diarrhea or ear infection. Very sick young infant means pneumonia, meningitis, or sepsis. So presenting symptom, maybe there is one presenting symptom, but it signifies different possible associated conditions. Like in case of cough or fast breathing, we need to rule out pneumonia, severe anemia, or fast breathing. So single diagnosis is inappropriate. So why integrated approach? So malnutrition, pneumonia, diarrhea, measles, malnutrition, pneumonia, diarrhea, measles, malaria, and other causes are the significant contributor of child death. So in this guideline, in this protocol, they try their best to cover these conditions because they are majorly factors, major contributors of unfair death, mortality as well as morbidity. Why integrated approach? Integrated approach is child-centered. And what are the conditions considered under this IMNCI? PD, pneumonia and diarrhea. 3M, measles, malaria, malnutrition are the major causes of death. PD 3M. 3 of 4 children seeking healthcare in developing countries suffer from one of these conditions. 75%. Children likely to be suffering from more than one condition. Often combination of this condition leads to fatal result, fatality. Making a single diagnosis may be difficult in health post setting or PSC setting, especially for health post PSC without having X-ray, without having lab diagnosis. The pinpoint diagnosis or single diagnosis is possible. Such children often need combined therapy for successful treatment. What are the advantages of integrated approach? It speeds up the urgent treatment and treatment seeking practices. Prompt recognition of serious condition, hence prompt referral. Prompt recognition, referral. Involves parents in effective care of baby at home. Involves prevention of disease by active immunization, improved nutrition, and exclusive breastfeeding practices. It's highly cost effective. We can save money of our country, our portion, in a portion, family. It avoids wastage of resource by using most appropriate medicine and treatment, reduces duplication of effort, and the partial success of individual disease control program. I don't want to go in detail regarding difference between IMCI and CB-IMNCI, but in the WHO, UNICEF, IMCI, and our IMNCI, 0 to 6 days only neonatal period is not covered under WHO, IMCI, but in our it's covered. Basic healthcare module not covered in our home visit by provider for newborn and young infant. No, here is yes. Home visit by the providers. It's this is IMNCI case management at first level health facility means health post or PSC referral level. So first level health facility, this one, this block. This one is referral level. This is home and family. So we have to access. ACS means history taking, and you need to assess for inspection, auscultation, or palpation. So based on this, we need to categorize children under pink, pre-referral treatment, or yellow treatment at facility or your health center, health post or PS, referral to higher center, where pediatrician or tertiary care level facility is available. Even we have medical officer with tertiary facility, then okay. Then green, home management. So when to refer? What about home and family management? What about the food and food and food management we need to discuss. This is master chart for IMNCI case management and referral process at home and hospital or referral level. This is for under 2-month children, which is almost same. The flow chart looks like this. Okay. Ask history taking. Ask means history taking. Look means inspection. Listen means auscultation. Feel means palpation. There is no percussion. Under 5 children, it's quite difficult. So they use this term: look, listen, and feel. Ask means history. You have to classify all young infants based on these under this, either red or yellow or pink or either green or red. Actually, red, yellow, and green. Now, so we need to go one by one. Okay, let me just discuss 1 or 2 slides, then I will stop. Check for possible serious bacterial infection, hypothermia, and jaundice. These 3 are very, very severe. So this is for 0 to 2 month children. Okay, 0 to 2 months. Always think about PSBI. PSBI means possible severe serious bacterial infection. PSBI, possible serious bacterial infection. Hypothermia, you know, hypothermia and jaundice. You need to ask history. Has the infant had convulsion? So what is convulsion? How to assess convulsion? It's beyond the scope of this class. You need to know what is convulsion. So how to access the convulsions? Maybe you heard this term in your, even you have found many cases during the ICM posting, or I don't know. But if not, then try to see some case scenarios in the YouTube. Okay, so how to assess convulsion, infants in convulsion, just search and you can find it. This is about ask, history taking. This is about look, listen, and feel means examination. I don't want to go detail. Okay, so tomorrow, so I'll give you brief discussion related to these components. Then you need to classify like PSBI, possible severe bacterial infection. Then what are the treatment modalities? What are the signs and symptoms? What is LBI, local bacterial infection? What is no bacterial infections? What are the treatment modalities? Everything. It's more clinical, okay, than public health. So you can see if infant has jaundice, how to manage. Hypothermia, how to manage. With diarrhea, how to manage. Dehydration, diarrhea, persistent diarrhea, dysentery, malnutrition and feeding problems, breastfeeding process, immunization, then young infants. Okay, so everything is here. So after that, assessment of 2 months to 5 years children. Okay. Ask, look, listen, very sick disease or main symptoms, fast breathing. So what is the cutoff point? Common question in your exam. Okay, so who belongs to severe pneumonia or very severe disease? Who belongs to pneumonia and no pneumonia? So what are the treatment modalities? What is the drug of choice? Everything we'll discuss in our upcoming classes. Okay. We need at least 5 to 6 classes. Ideally 6, if not possible, within 4 classes we'll try to complete, but I hope we can go further because this is very important. If time permits, then I'll continue further. Hopefully next week we don't have any classes for community medicine and maybe other classes. But in near future, we'll discuss more and more. And we have some disease under pure medicine section. We'll discuss those also. And it's ongoing process. Fine. We have 51 participants, including me and BMC online. So we have 49, I think 48 only. 58 students present. Hope they are physically, mentally, and socially present here. Do you have any questions related to today's class, or do you want to get anything more so that we can learn together? If not, I need to stop here, and you'll get all the recordings through my page and PowerPoint through my website. So if you have any question, any queries, so let us discuss. If not, I need to stop. But do you have any questions before closing this session?
No, sir.
Okay, I think it's easy to understand. Okay, and hopefully, uh, because this is good for a practical point of view also. So please read again and again, and you can find all the videos from my page and slides from my website. Soon we'll launch Moodle platform also. Hopefully it will be more easy. We started training from today with our faculties. Hopefully can incorporate those things also. So